Okay, so this week is going to be kind of busy because we're going to be finishing up on the nervous system. But remember that you also have your lab practical at the end of the week. And so remember that you need to study the cranial nerve diagrams, the cranial nerves, and the brain model, and also the regular spinal nerves and the nerves that go out and innervate the muscles in the upper arm and lower leg. Okay. The other thing is that I'm not going to have you turn your lab notebook in till Monday. So you want to make sure that you have your lab notebook kind of all put together when you come to the midterm exam. So you'll take the exam and you'll turn in your lab notebook, and then I'll give those back to you on Friday. Okay, so lab practical on Friday, lab notebook due on Monday, and your midterm exam. So we should have time for a review. We're going to have one more quiz. So on Wednesday, we'll have a quiz over the autonomic nervous system. And then we'll have time for a review, kind of a general review over everything before the midterm exam. Are there any questions before we start today? Hello. Okay, so I have somebody else come in? Okay. Harley needs one. Okay. So this was the diagram that we explored in class last week. And so I thought that it would be good for you to review it by labeling it, and we're going to label it together. And so remember that the top one is somatic. So this would be the somatic division. Right? So remember that includes the neurons, the motor neurons that innervate skeletal muscle. And so you'll notice that the nerve cell body is in the central nervous system. So this is the CNS, right? So the nerve cell body resides in the CNS, and then it sends a long myelinated, so that's heavily myelinated axon out to the skeletal muscles. So what would be the hormone, or not the hormone, but the neurotransmitter that is released in the synapse between the motor neurons and your skeletal muscles? Acetylcholine. So this is ACH, right? So that's acetylcholine. Okay. And you'll notice that it is excitatory. Oh, you need one, sorry. It is excitatory. Okay. So this would be autonomic. Oops, wrong screen. This would be autonomic. So remember, the autonomic does not include neurons that innervates the skeletal muscle, but rather cardiac muscle, smooth muscle, and glands. And so you'll notice that right here, we have a ganglia. And so remember that we talked about how we can have pre-ganglionic neurons and post-ganglionic neurons. So this would be my pre-ganglionic neuron. And this would be my post-ganglionic neuron. Okay. Now, this would be the parasympathetic division right here. And it releases into the synapse. It releases the same type of, actually, is that parasympathetic? No, this would be sympathetic, sorry. So this is sympathetic. And this is parasympathetic. Okay. So it's important to realize, and I don't think I made this point previously, that all the preganglionic axons always release acetylcholine. And so this would be acetylcholine right here. So this is ACH, right? This is ACH. This is ACH. So in your diagram, I think they're all designated with a little triangle versus a little circle, okay? So those all release acetylcholine into the synapse. Now, one of the really interesting things about this one is that you'll notice that it doesn't have a ganglion, but it actually immediately synapses with the nervous tissue in the adrenal gland. And so they actually think that the adrenal gland, the center of the adrenal gland, which is nervous tissue, the outside is gland, but the inside is nervous tissue. And they think that that is actually a misplaced ganglion during development. Instead of it just being a separate ganglion, it actually becomes a ganglia inside of a gland. And so this is the reason why, in this particular instance, there is no ganglion. There's just the adrenal gland. So you would want to write adrenal gland right there. And it is the center of the adrenal gland. So it would be the medulla. And that'll be important when we talk about the corticosteroids and the other hormones that are produced by the cortex of the adrenal gland. Okay. So in this particular instance, you see here that this is norepinephrine, and this can be abbreviated as NE. Okay, so that's norepinephrine. This would be norepinephrine. And remember that we talked about how the sympathetic nervous system can have a long-lasting effect on our body, because norepinephrine is not only a neurotransmitter, but it is passed as a hormone into the circulatory system. So this is showing how it goes into the circulatory system and then goes out throughout your entire body. And so, for example, it could cause glucose to be released, it could cause the burning of fat, it could cause an increase in your metabolism, all those things that are associated with the sympathetic division of the nervous system. Now notice that it is excitatory or inhibitory depending upon the synapse, and that's what we're going to talk about in a minute, okay? Actually, I don't want to, you just think that's a negative. So I just was circling that. Okay, so this is parasympathetic, and so this would also be ACH, right? So the parasympathetic nervous system only uses acetylcholine. It doesn't use norepinephrine as a neurotransmitter. So on the back of that, you should notice that there are there's a diagram here, or not a matching fill in the blank kind of thing. And so what I want you to do is to take a few minutes and in your notes, and you can use your phone too, and you can find somebody to do this with, so it kind of goes along a little faster. So these are some of the things that you want to study for the midterm exam. So I could have this as a multiple choice question. So I could say, which one of these is caused by the parasympathetic nervous system, and which one of them is caused by the sympathetic nervous system? So you need to know these for the midterm exam. So I'm going to turn on the light, and we're just going to take maybe 10 or 15 minutes to write the P and the S's into the blanks. So remember that parasympathetic is rest and relaxation and digestion, and the sympathetic nervous system is excitation, fight or flight. And also remember that there are certain things that are only innervated by the sympathetic system and not the parasympathetic. Okay, so go ahead and work on that for a few minutes. Oh no. Okay, so let's look at these. So number one, pupil dilation. Sympathetic or parasympathetic? Sympathetic, right? So when you're relaxed, your pupils constrict. So we showed that in the ciliospinal reflex, that autonomic reflex, when somebody comes up in the back of you, right, and stimulates the back of your neck, then that causes your pupils to dilate, where you take in more peripheral vision. So which one of them promotes urination? Parasympathetic. Dilates bronchioles? Sympathetic. Why do you think that is the case? Right, so your breathing increases, you get more oxygen, and that powers your muscles for fight or flight. Increases metabolic rate, so it makes you hot. Sympathetic, right? Causes lens to bulge and allows for near vision. Parasympathetic, so the sympathetic causes the opposite, so the lens flattens out so you can see far away. So remember the idea of dual innervation. The parasympathetic and the sympathetic both innervate the muscles that have little ligaments that can control the shape of your lens. Which one increases glucose uptake from the blood? So not the putting in of glucose, but taking glucose out of the blood and storing it in the liver, for example. Parasympathetic, right? So that's relaxation. How about leads to orgasm in males and females? That was sympathetic. Okay. Stimulates copious sweating? Sympathetic. So does the parasympathetic even innervate our sweat glands? No, right? So that's one of those unique innervations. How about increases peristalsis in digestive tract? Parasympathetic. Stimulates fat breakdown or lipolysis. Lipolysis. Sympathetic, right, because that can be used as energy. Stimulates secretion of watery saliva. Parasympathetic. Excites gallbladder. Gallbladder is digestion, so that would be parasympathetic. So the gallbladder releases bile into the small intestine, okay? Increases heart rate. Sympathetic. Causes erection in male and female genitalia. Parasympathetic. So remember the whole sexual response requires that first you're relaxed, but then you have to override that, right? And then the sympathetic actually leads to orgasm. Causes both vasoconstriction and vasodilation. Sympathetic. So remember we talked about how that is vasomotor tone. And so remember that the sympathetic nervous system is the only system that innervates the smooth blood, or the smooth muscle in the blood vessels. What is pileoerection? Yes, so when your hair stands up, so what do you think that one is? Sympathetic. Stimulates renin release from the kidney. That's actually sympathetic. The only sympathetic is what innervates the kidney. The parasympathetic does not innervate the kidney. So you can kind of think of, remember that kidney and the renin regulate blood pressure, and the sympathetic division is what regulates blood pressure. Okay, stimulates the adrenal medulla to release norepinephrine. Sympathetic, right? So this is my sympathetic, right? This is its innervation of the adrenal glands. Includes stimulation of the heart via the vagus nerve, parasympathetic, and stimulates the production of tears, parasympathetic. Okay. Okay, so the next thing that we need to do is we need to talk about the receptors. And so we can talk about the acetylcholine versus norepinephrine, and then the specific receptors that they bind to. And so when we talk about these neurons, we can talk about what are called cholinergic fibers. Does anybody remember what a fiber is? what is a fiber technically in terms of like the cell, the neuron? Right? It is a myelinated axon. So any myelinated axon is a fiber, right? So cholinergic fibers are the axons that release acetylcholine. Okay. So when we look at the receptors that bind acetylcholine are either called nicotinic or muscarinic. And the reason why they have these names is these are the other things that also bind to the exact same receptors, okay? So nicotinic is named after the fact that nicotine binds these receptors. And muscarinic, this is a poison that is produced by mushrooms. And so this is not psilocybin, it's not the hallucinogenic mushrooms, but it's the poison that would bind to the same receptors or would bind to these particular receptors. So it's a chemical that binds to this receptor. Okay, so when we look at the difference between these, this one is always excitatory. And it also is direct acting. This one can be excitatory or inhibitory, depending upon where it is, and it is indirectly acting. So remember that the difference between direct and indirect has to do with whether or not there's a secondary messenger involved. So this one directly, this receptor directly binds acetylcholine, right? So this would be, for example, in the synapse with the skeletal muscle. So the type of receptors that are on your skeletal muscle cells are called nicotinic. They bind acetylcholine, right? And they are direct acting, and that means that it's fast, right? So it tends to be fast. But in this particular instance, so I'll say it's faster, but acetylcholine is always shorter acting, okay? Because it is broken down readily by acetylcholine esterase, which is an enzyme that is in the synapse, and so it doesn't allow continued stimulation. So what drug inhibits the effect of acetylcholine esterase? It's a drug that's used in warfare. Sarin, right. So sarin would bind, or actually would inhibit this and cause acetylcholine to bind to the nicotinic receptors and cause continual muscle contraction. Okay. So this one is indirect acting, so it is slower, right? But it is also shorter acting. So nicotinic would be on those receptors would be on the post-ganglionic cells. It is slower but shorter acting than norepinephrine. It's slower, it's indirect. Was that your question?
I was
okay.
Confused because the name was faster and shorter acting.
Yes, so this is shorter acting than the next ones that we're going to talk about, which are norepinephrine. Okay, so these are on the postganglionic cells, right? So on their dendrites, and these are also on skeletal muscle, right? So muscarinic is found in the other synapses. So we'll just put other synapses with organs and glands. and glands. So for example, right, the vagus nerve would be a cholinergic, would have cholinergic fibers in it, and it would synapse with the heart muscle. And on the heart, near the SA node, would be muscarinic fibers. And the muscarinic receptors. And the muscarinic receptors bind acetylcholine, and if it's parasympathetic, that would actually cause a decrease in heart rate. So we'll put like, it decreases heart rate, right? But it increases the motility of the digestive gland, of the digestive system, Okay, so this is parasympathetic. Because remember that the sympathetic nervous system does not release acetylcholine. So muscarinic receptors are associated with the parasympathetic division of the autonomic nervous system. Okay. So the other fibers that are released or that are found in the ANS are called adrenergic. Okay. So just remember adrenaline. So remember that norepinephrine has another name, which is called adrenaline. So these would be adrenergic fibers, and they release norepinephrine. So these would be the postganglionic axons of the sympathetic division. Okay. When we look at the receptors, they do not nearly have as cool a names as the muscarinic and nicotinic, because they are just labeled alpha 1 and alpha 2. And then beta 1, beta 2, that's a comma, beta 2, and beta 3. Okay. So remember, when you think about norepinephrine, you think, oh, that's got to be excitatory, but it's not always excitatory in the synapse when it binds to these receptors. So it depends upon the receptor, whether or not it is excitatory or inhibitory. And so these ones are indirect acting. So when norepinephrine binds to them, it has to cause a secondary messenger, kind of a cascade of events to occur. And so this is indirect, it is slower, but it is longer acting. Right? And that's because norepinephrine is not readily broken down in the synapse. So it either has to be taken back up by a neuron, or it has to just kind of diffuse away from the synapse. So we say that in this particular instance, norepinephrine does not break down in the synapse, which is why it is longer acting compared to acetylcholine. Okay, so just to describe how these different receptors might act, just as an example, and then I'm going to actually give you another worksheet. So when we look at the alpha-1 receptor, so this one would cause, this would actually be found on blood vessels, and it would cause the constriction of blood vessels. So this is constriction of blood vessels. Okay, so if the norepinephrine binds to the alpha-1 receptor, the blood vessel will constrict. But if it binds to beta-2, this actually causes the dilation of the blood vessels. Right? So this means that it can be both excitatory or inhibitory. right? So excitatory would cause the smooth muscle to contract. Inhibitory would cause the smooth muscle to relax, okay? So also, if we look at alpha 2, this actually causes the cardiac muscle to relax. If we look at beta 1, this actually causes the heart muscle to contract, so the cardiac muscle contracts. So it depends upon what receptors the fiber is innervating, the adrenergic fiber. So sometimes there are drugs that can be used to bind to these receptors to decrease their effect. And so we can, if we know what is binding to that receptor, we can actually use drugs. And so a good example of this is what is referred to as beta blockers. And does anybody know what beta blockers specifically are used to treat? Heart, right? So let's say that you have tachycardia, which is elevated heart rate, and that tachycardia is causing, or could cause a fatal arrhythmia. So it could cause ventricular fibrillation. And so beta blockers would block this, right? So it would block the B1 receptors on the heart. And so it would prevent the heart rate from going too high. So this specifically is used to prevent the heart rate from going too high. So tachycardia. Now the problem when you take beta blockers is that sometimes it inhibits your ability to move quickly, because say for example you're on beta blockers and you want to run up a flight of stairs, you'll just start running and your heart will not be able to keep up. It won't go fast enough to pump oxygen and stuff to your muscles, and so you won't be able to do that, right? So it's kind of a bummer, because remember the heart needs to respond when you need more oxygen and nutrients to your muscles. And so beta blockers kind of prevent that. So it makes people feel really kind of unhealthy because they're not able to do some of the things that they used to be able to do, like climbing a flight of stairs, for example, without having to rest frequently. Okay, so this next handout that I'm going to give you is a table from your, and I'm sorry it's so small, I should have increased the size, but it's a table from your textbook, and then there's questions on the back. So what I'd like you to do is, using the table information on the front, see if you can answer the questions on the back of this handout. You guys finished? Oh, there's one missing. There should be a J. And J should read albuterol. So J is albuterol.
Are we gonna need to know the back of this paper?
Yes. The back of the paper meaning, yeah. So these.
As in the front of the paper.
Oh, just as it relates to this one, to the back. So you should know that what is used to treat tachycardia and high blood pressure by blocking. So that would be E, which is propranolol. Okay, so which one of these drugs would you have in cold medicine? Phenylephrine, right? Phenylephrine is like in Benadryl, right? In cold medicine, it's a nasal decongestant, right? So it's in also like, it's actually not Benadryl, I'm sorry, it's in Sudafed. And so that is the one that you now have to have prescription for, right? Because people can turn it into methamphetamines. So one is D, okay? Which one binds to nicotinic receptors meant to bind acetylcholine? That one's pretty easy. That one would be nicotine, right? So nicotine increases the heart rate. It also has an effect on the central nervous system. So it kind of has an effect on the mood, you know, and it kind of also increases your ability to focus. So it kind of increases your arousal and your ability to pay attention. Okay, so used to treat tachycardia, E would be propranolol. I don't know how to say that. Okay, so 3 is E. Inhibits the breakdown of acetylcholine and is a warfare agent. That would be H, sarin. This is a drug that mimics acetylcholine and is used to treat glaucoma. Anybody gets that one? Yep, C, pilocarpine. What binds to adrenergic fibers and dilates bronchioles? That's the one that I didn't have on that list. So that would be albuterol. Okay. So when people have asthma and they're like, I need my inhaler, what they're inhaling is albuterol. So albuterol is something that is a drug that would bind to the same receptors on the bronchioles as norepinephrine. It's released by cholinergic fibers and can bind to muscarinic receptors. That would be acetylcholine, so 7 is B. Released by adrenergic fibers and can bind to alpha and beta receptors. That would be I, norepinephrine. Which one? This one wasn't actually on your table. Which one, or which one of the drugs blocks muscarinic receptors and is administered before surgery to prevent salivation? Atropine, yes. And which one inhibits acetylcholinesterase and used to treat myasthenia gravis? That would be G, right? G, neostigmine. Okay, so the reason why these drugs work is that they bind to the same receptors as either acetylcholine or adrenergic, right? Or the, acetylcholine or the norepinephrine. And so that's why they can have kind of an effect by blocking the receptors and preventing action potentials from being generated. Okay. Any questions about that idea? Nope. Okay, I'm going to skip over this one right here because I want to talk about, okay, ANS and CNS. Okay. So in your book, there's, at the very end of this chapter, there's a discussion about how the central nervous system and the autonomic nervous system interact. So remember that the autonomic nervous system is part of the peripheral nervous system, and it can go into the spinal cord, or it can travel via the cranial nerves right into the central nervous system. And so where most of this information is integrated in the CNS is the hypothalamus. So we say that the hypothalamus is the main integration center for ANS, right? So if we're talking about fibers coming from the lungs, they go into the spinal cord, then they go up, right? And they also travel through the brainstem. So this is where it is integrated, but it can go from the spinal cord, right, to the brainstem, to the hypothalamus. And there is some ability to go from the hypothalamus to the cortex. Okay, so that's kind of a pathway that the spinal nerves at least travel this way. And so the cortex, we have some ability to affect the autonomic nervous system. And so this is sometimes referred to as biofeedback. Right. So through biofeedback, the cortex can gain some control. So the big example of this is in heart rate, right? So you can be hooked up to a heart rate monitor, and then you can learn to keep your heart rate low, right? So you can affect your heart rate by watching where it is, and then just by focusing on that and lowering your heart rate automatically. So there is some control. You could also think about some of the reflexes. So like the gag reflex, some people have the ability to override the gag reflex so that they can swallow things like swords, for example, right? And that is just through biofeedback, you have some control over the reflexes that are associated with the autonomic nervous system. So remember that the cortex is the only part of the brain that is conscious. So in your book, they have a diagram that shows that in your book. I forget to put that there. I guess I see this in the previous page. Oops, I don't have it. So there's a diagram in your book that shows the pathway from the hypothalamus up through the brainstem. Now remember that the brainstem contains the medulla oblongata. So I wanted to talk about that. So this is the medulla oblongata. And so this is the autonomic reflex center, right? So this is our reflex center. So that would be an unconscious response to, for example, lowered blood pH. If the blood pH is too low, the brainstem might respond to that through also being integrated by the hypothalamus, might respond to that and increase breathing rate to increase blood pH. Okay, so the last thing I want to talk about in terms of the autonomic nervous system are some disorders that are associated with these. And so when we look at hypertension, hypertension is high blood pressure. And your blood pressure can respond to stress hormones. Right, including norepinephrine. So normally, the autonomic nervous system regulates blood pressure. And remember, we talked about why the kidney is important in this, in that the kidneys have some really important capillaries. And if the blood pressure is too high, you can damage the capillaries in your kidneys. And if the blood pressure is too low, then you don't produce enough filtrate in your kidneys to get rid of all the urea that is in your blood. And so generally we have the ability to maintain homeostasis. So hypertension would be an autonomic nervous system disorder because the sympathetic nervous system is causing vasoconstriction, which increases blood pressure. Right? So vasoconstriction increases blood pressure. Can damage capillaries. Can also damage blood vessels and lead to atherosclerosis, right? So it can cause damage to kidney damage. And it could also lead to strokes. Right? And damage to blood vessels. So blood vessel walls, and if those walls get damaged, then you get atherosclerosis, So you get inappropriate plaque formation in the blood vessels, which can cause blocking of the blood vessels and can lead to things like heart attacks. So hypertension is considered to be an autonomic nervous system disorder. Okay, so there is another one that your book doesn't actually talk about, but I think that is important to talk about because it is relatively common these days for some reason. And there's actually been clinics that have been set up just specifically to treat this. And this is called chronic pain syndrome. In the past, this actually had another name, which was called reflex sympathetic dystrophy. Oops, let's spell that right. Dystrophy. And this is abbreviated as RSD, reflex sympathetic dystrophy or dystrophy. So when we look at this is actually believed to be due to the overactivation of the sympathetic nervous system. So the sympathetic nervous system becomes kind of hyper. And one of the really weird things about it is it could be caused by a relatively not severe, relatively minor injury, but then what happens is that the injury heals, but the pain stays, right? So for example, I actually had a student whose husband had this, and what he did is he cut his hand using a power tool, but it wasn't like anything really bad. It was just like he had to go to the doctor and get it sewn up, right? So it was his thumb. And then what happened is the sympathetic nervous system caused the blood vessels to dilate and caused blood to rush to it. And then that limb started to get swollen. And then the skin developed a rash. And then it kind of started spreading throughout his body. So even after the wound healed up, he would experience kind of excruciating pain in this limb. And with chronic pain syndrome, it's really depressing because when the doctor looks at you, he's like, there is nothing wrong with you. Why are you in pain, right? And so it is something that we don't really understand, but it seems to be a sympathetic reflex that is causing the pain, okay? It generally, it might lessen and go away, but generally some people are on drugs for the rest of their life. So they're just experiencing excruciating pain. Yes.
Now, is that kind of like fibromyalgia? Because I know that that's kind of something that's controversial.
Yes, this is different from fibromyalgia. So what they think with fibromyalgia also has to do with blood vessels. So they think that the sensory receptors in the blood vessels, for some reason, aren't working properly. This is a little bit different than that, but it's kind of similar in that it's pain associated with blood vessels, right? Okay, so we could have, for example, a minor injury, and it could be maybe an injury that they don't even aware of. So it could be like you fall down, right? And you get a bad bruise on your bone, and then that's your minor injury, right? So this might be something you don't even go to the doctor for, right? And then after the minor injury heals, the sympathetic nervous system causes swelling and pain, right? So this pain is itself the disease. So the pain is the disease. So when we think about pain, we think of it as being kind of important because it gives us some information about damaged tissue, right? And there's got to be something wrong to be causing the pain. But in this particular instance, there's nothing wrong. It's just the pain has become the disease. And so I'm going to show this little video that talks about this. It's a TED Talk. It's like 14 minutes long that talks about the mysteries of chronic pain.
I'm a pediatrician and an anesthesiologist, so I put children to sleep for a living. And I'm an academic, so I put audiences to sleep for free. But what I actually mostly do is I manage the pain management service at the Packard Children's Hospital up at Stanford and Palo Alto. And it's from the experience of about 20 or 25 years of doing that that I want to bring to you the message this morning that pain is a disease. Now, most of the time you think of pain as a symptom of a disease, and that's true most of the time. It's the symptom of a tumor or an infection or an inflammation or an operation. But about 10% of the time, after the patient has recovered from one of those events, pain persists. It persists for months and oftentimes for years. And when that happens, it is its own disease. And before I tell you about how it is that we think that happens and what we can do about it, I want to show you how it feels for my patients. So imagine, if you will, that I'm stroking your arm with this feather, as I'm stroking my arm right now. Now I want you to imagine that I'm stroking it with this. Please keep your seat. A very different feeling. Now, what does it have to do with chronic pain? Imagine, if you will, these two ideas together. Imagine what your life would be like if I were to stroke it with this feather, but your brain was telling you that this is what you were feeling. And that is the experience of my patients with chronic pain. In fact, imagine something even worse. Imagine I were to stroke your child's arm with this feather, and their brain were telling them that they were feeling this hot torch. That was the experience of my patient Chandler, whom you see in the photograph. As you can see, she's a beautiful young woman. She was 16 years old last year when I met her, and she aspired to be a professional dancer. And during the course of one of her dance rehearsals, she fell on her outstretched arm and sprained her wrist. Now, you would probably imagine, as she did, that a wrist sprain is a trivial event in a person's life. Wrap it in an ace bandage, take some ibuprofen for a week or two, and that's the end of the story. But in Chandler's case, that was the beginning of the story. This is what her arm looked like when she came to my clinic about 3 months after her sprain. You can see that the arm is discolored, purplish in color. It was cadaverically cold to the touch. The muscles were frozen, paralyzed. Dystonic is how we refer to that. The pain had spread from her wrist to her hands, to her fingertips, from her wrist up to her elbow, almost all the way to her shoulder. But the worst part was not the spontaneous pain that was there 24 hours a day. The worst part was that she had allodynia, the medical term for the phenomenon that I just illustrated with the feather and with the torch. The lightest touch of her arm, the touch of a hand, the touch even of a sleeve of a garment as she put it on, caused excruciating, burning pain. How can the nervous system get this so wrong? How can the nervous system misinterpret an innocent sensation like the touch of a hand and turn it into the malevolent sensation of the touch of the flame? Well, you probably imagine that the nervous system in the body is hardwired like your house. In your house, wires run in the wall from the light switch to a junction box in the ceiling, and from the junction box to the light bulb. And when you turn the switch on, the light goes on, and when you turn the switch off, the light goes off. So people imagine the nervous system is just like that. If you hit your thumb with a hammer, these wires in your arm, that of course we call nerves, transmit the information up to the junction box in the spinal cord, where new wires, new nerves, take the information up to the brain, where you become consciously aware that your thumb is now hurt. But the situation, of course, in the human body is far more complicated than that. Instead of it being the case that that junction box in the spinal cord is just simply where one nerve communicates with the next nerve by releasing these little brown packets of chemical information called neurotransmitters in a linear one-on-one fashion. In fact, what happens is neurotransmitters spill out in 3 dimensions, laterally, vertically, up and down in the spinal cord, and they start interacting with other adjacent cells. These cells, called glial cells, were once thought to be unimportant structural elements of the spinal cord that did nothing more than hold all the important things together, like the nerves. But it turns out the glial cells have a vital role in the modulation, amplification, and in the case of pain, the distortion of sensory experiences. These glial cells become activated, their DNA starts to synthesize new proteins which spill out and interact with adjacent nerves, and they start releasing their neurotransmitters. And those neurotransmitters spill out and activate adjacent glial cells and so on and so forth, until what we have is a positive feedback loop. It's almost as if somebody came into your home and rewired your wall so that the next time you turned on the light switch, the toilet flushed 3 doors down, or your dishwasher went on, or your computer monitor turned off. That's crazy, but that's in fact what happens with chronic pain, and that's why pain becomes its own disease. The nervous system has plasticity. It changes and it morphs in response to stimuli. Well, what do we do about that? What can we do in a case like Chandler's? We treat these patients in a rather crude fashion at this point in time. We treat them with symptom-modifying drugs, painkillers, which are frankly not very effective for this kind of pain. We take nerves that are noisy and active, that should be quiet, and we put them to sleep with local anesthetics. And most importantly, what we do is we use a rigorous and often uncomfortable process of physical therapy and occupational therapy to retrain the nerves in the nervous system to respond normally to the activities and sensory experiences that are part of everyday life. And we support all of that with an intensive psychotherapy program to address the despondency, despair, depression that always accompanies severe chronic pain. It's successful, as you can see from this video of Chandler, who 2 months after we first met her is now doing a backflip. And I had lunch with her yesterday because she's a college student studying dance at Long Beach here, and she's doing absolutely fantastic. But the future is actually even brighter. The future holds the promise that new drugs will be developed that are not symptom-modifying drugs that simply mask the problem as we have now, but that will be disease-modifying drugs that will actually go right to the root of the problem and attack those glial cells or those pernicious proteins that the glial cells elaborate that spill over and cause the central nervous system windup or plasticity that so is capable of distorting and amplifying the sensory experience that we call pain. So that I have hope that in the future, the prophetic words of George Carlin will be realized, who said, "My philosophy, no pain, no pain." Thank you very much.
It's time for Ted.
Okay. Okay, any questions about that? No. So the glial cells might be playing more of an important role than we now know. Okay, so we're going to stop there for today. And so remember that you have a quiz Wednesday over the autonomic nervous system.
You're trying to tell us, right?
Yeah,
Quiz and lab practice.
I know. I'm just trying to get you all prepped and ready. Yep. Yes. Yep, that'll work. Yep. Later.
Oh, goodness gracious. She said that she wants to take some nap. So it's like,
Pretty big town.
Yeah.
Like,
why does, I mean, she turns out to Athena. This bitch to check and see what next to do.
Doesn't Dee really think that she's not gonna screw with them and promise me?
Oh my God, excuse me. No, because her limit of driving is like. To take 20 miles.
I was you be more concerned with what was convenient for you, but you're the one that's going to start and trying to work and everything. And he's like,
Yeah,
reach out.
my babysitter now.
Yeah.
Because I did have somebody else watching her, or watching this. But every time I turn around, the kids are sick, they've got something. And I'm like, okay, you never take your two little ones anywhere. How are they always sick? Now they have pink eye, and they have a bunch of other shit wrong with them. Breathing problems and pink eye. I'm like, yeah, I don't want my son there.
I know. But you-
I'll sit here and watch you guys shit. What's up, Sandy?
All the flowers.
They were technically for people graduating.
Where the frick is mine?
They were for women that were graduating because it's May.
That's sexist.
Shut the fuck up.
That's my difference.
Did you? Isn't he a dog? Very much so. He doesn't. No.
Oh, you don't need.
I need that, I need chapter 9. It'd be nice. Go bathroom. I told her about the shit. So I can cheat.
It's okay. What do you think we were doing in the cafeteria before you got there?
I don't know.
I was writing the next paper for her, and she's so.
I haven't done my class that brings pizza on finals and stuff. And what it does is inside the pizza box, it has some milk written down, pizza on top of it. So every time he goes to make an answer. I have to give him an A for effort. That was like ingenious.
And the teacher hasn't figured this out yet?
Well, no, last term I took,
You know what? I honestly think some teachers really don't care.
no, I one time there were two girls that would literally, copy after each other when there were like quizzes for every slide. And I said something to the teacher, because I was frustrated with the fact that I'm busting my ass and I'm gonna get a C.
Right, and they're probably getting something better.
And teacher was like, no, they'll eventually get my product to them. And she's like, it also will reflect in the final, because when they get it back on their final, if they're cheating, and she said that's where everything gets made up at. So there's no sense hassling them during the term, you know, and you just wait until
She
the
is
final.
right, I mean, yeah.
Yeah, and it makes sense, so every time I see it now, I just kind of laugh. Very good, good time.
Thank you.
Have fun. I'm up to class.
Loads.
So I gotta go figure out what my exam grade is, because I'm pretty stinking sure I probably got a D.
Got the D?
I always do great. I get A's in all my assignments, and then I always get a D. Only once did I ever get a B, and I just about cracked my pants because I didn't study on that one, and somehow multiple choice worked in my favor. But yeah, I always get a D, and it equals up to like a C+.
That's kind of where I'm at.
So,
Yeah,
I take all the quizzes,
Yeah.
pretty much, C's,
yeah,
B's, D's,
yeah.
back and
I think it's been a
But I get
year.
100% on
I
everything
think
else.
it's been a year and a
I don't know
half
how
since
that
I've gotten a B on an exam. You know,
Chris.
but generally it's C's and D's.
Yeah, I know.
I'm saying the
What are the flowers for, girls?
Yeah, don't even ask. We're not.
I'm already
They're
depressed.
walking around giving
I'm
them
depressed
to
because
people
I
that
didn't get a
are
flower.
graduating this year.
Yeah.
That is just no fair.
Graduating.
He's
from
like,
my
I don't care, I gotta get rid of these flowers.
You're like, give me a calendar calendar.
Yeah, exactly. Exactly.
It'll be fine. That's awesome. Oh my God.
I said that I wasn't graduating and they wouldn't give me flowers. It's a different person now.
Yeah. It was a cute little black guy.
Yeah, he's the one that offered, I was graduating to begin with. He said it gave them to us.
I said, no, I wasn't graduating.
Yeah. I said, no, I wasn't graduating. He
You
listened
go
to
buy
me.
your own damn flowers.
Well, then I guess I'll see you next year, huh?
So guess what I just did over the weekend? You know, I was struggling with math. Yeah. So I got hold of my Treasure Valley instructor and was talking to her, and I said, you know, I'm just ready to shoot the exam. Well, here's the deal. I skipped 2 classes for Treasure Valley. Their curriculum is the same.
Yeah, that's how it is here for Portland, okay? So my math 111 class that I'm in right now, that's where I was supposed to fucking start. Because, so in Portland, it's math 20, 60, 65, 7, or no, 20, 60, 65, 95, 111, right? Here, they do 25, 70, 95, 111,
Right.
okay? So the 20 and the 25 are the same.
Yeah.
Here's math 70 is Portland's math 60. Their 95 here is Portland's 65. Their 95 here is their 65. Their 111 here is their 95. I was supposed to be in 111 last term, and I redid a whole class I didn't need to do.
Really?
Yeah, so, here, what are you doing tonight?
Studying.
Okay, when I get out of lab, I have to go to work. Okay? I'm on shift, like, there's no waiting for the bar to open because it's already open, okay? Bring your dumb little butt
Are you
down there. Yes.
I just feel bad about doing that.
Okay, no, hold on. This blue notebook right here, this wonderful little psychology notebook right here, it is open, sitting on the counter. Put my reading glasses, I sit there, I'll read a chapter, a paragraph or two. Yeah.
Well, and what they're trying to do is, they emailed this math instructor for 25 to 60 drop off down there. So, okay, if you're sure.
I'm sure. Because
Yeah, because I'm straight up telling you, I haven't even done homework much because I don't freaking get it.
Okay. See? And the tutor is expecting you to already be there. And he's just teaching you how
I need the concepts of it,
you need the concepts of it.
because I don't get it.
And I can give you the concepts.
What math are you in?
70.
70, I
Play out
just,
Vetch or Beach or whatever her name is.
he goes so fast, I'm certain he'll run across the room and jump up on the table.
Oh, you're in, you don't have it online.
He will run across the room and jump on the table.
And he just gets so excited. The problem is, I did 20 and 25 at Treasure Valley. So I don't know if you heard me, but I was emailing my instructor that because I was telling her. I skipped 2 classes. 2, so I'm just sitting there and I'm like,
Yeah. I'm doing that one online and I'm
which
like,
one are you in?
70.
Are you not getting it either?
I kind of, but I'm doing it online and the teacher's like totally freaking laid back and
Who's your instructor?
la la la, Teresa Vetch or Beach or something. And she's like, anytime you want to send me a message and we can video chat or I'm here and I can meet
That's
you.
so
And
nice.
she's just like totally laid back and she'll give you
That's
chances to do this and yeah, in the assignments that are supposed to be due every night, she's like, I don't care as long as they're done by the test date.
Nice. Well, this guy, I have to have everything freaking broke down, everything.
Where is
Well, he's like, you know what, you guys should know this by now. So he goes from A to here's your answer, here's this, and I'm like, I don't even know what a freaking Y103 intercept.
And the thing is online,
Yeah, well,
they've
yours-
got
Good.
the assignment, you can go to the reading, and then they've got videos. And so they post these videos, these little, 2 to 5 minute videos that you watch, and then it breaks down and explains exactly how to do it.
That is what I need.
Hey, did you make flashcards, honey?
No,
Did
I emailed you, our cute little guy down at the end.
Kevin.
Hey,
He's not. A smart one, we don't know your name. Did you make flashcards for the class?
no.
You did.
Just have to be young and smart.
I know.
You know?
And I get.
I read books.
So fast.
Because I was making flashcards.
Yeah.
And I was gonna see if you duplicated something, I thought maybe.
No, they do help though.
Yeah, I was thinking if you had.
I just finally just said, I'm not
I'm not sure
focusing
what
on
to put
biology.
Mhm.
I put all the quiz, everything that was on our quizzes, but I don't even know, but I was thinking maybe I just use
So
that.
maybe you don't understand, and then the back would be the definition of it,
I thought, yeah.
or something like that.
No.
Like the words and then the questions that you have to follow, sentence questions, what is the system?
I thought I had everything done last night. I was hoping somebody would already have like flashcards.
No, I'm way lower and
I can copy.
Keep that.
Would you explain something to me? No. It's making my terrain.
Pyruvate, whatever that is. I'm struggling for some reason getting it to sink in how that all.
That's the first part of metabolism. So we need
Glycolysis, yes.
glycolysis.
Okay, I've got that part. So what is pyruvate?
Pyruvate is the end product of glycolysis.
That is the very end. For some reason, I kept.
So we go from glucose
I know, I actually
to
know that.
pyruvate. Glucose is broken down into
It only
2
makes
pyruvate.
2 ATP.
Thank you.
I have a question for you too.
Yeah.
So when it's NAD plus H, is
Uh-huh.
that oxidized? Because
Um,
NADH is.
oxidation is losing, that would be reduced. Reducing is gaining, so NAD converted to NADH,
That's reduced,
that's reducing.
because you're bringing in a hydrogen.
Yes,
Okay.
and that has an electron with it.
I can help in psychology. I can help.
Yesterday, what I would
Writing
do
is,
is I
but
would
somebody's gotta
read
help
it.
me do this.
I told you I would, you just gotta be, willing to get together.
Isn't
I don't have
NAD,
words.
get rid of the B vitamins or something like that? From niacin,
You know, I don't know where we get
and
NAD.
then FAD is probably from like riboflavin.
Hmm, I don't know.
I think so.
Did you take nutrition?
Yeah, it's a.
Oh, okay. So you
I
remember.
know, yeah, I'm trying to. Well, are you, don't forget to record the class today, please.
Okay, I'm working on it. So if you talk to me,
Well, Walmart
I might-
was all out of recorders, and so we've all been jumped in. We ordered them on Amazon, and so
We've all ordered our own.
mine won't be here tomorrow, so.
you're gonna do the old fashioned recording, huh?
Yep.
Just in
Because
case.
then I, like I told you, I go to bed listening to my head. No, please, don't just think it. I swear. That is my osmosis.
We don't have a quiz in class today, right?
No,
Okay. Just double
You
check.
better be sure about that, because I already asked you that. You on camera.
I was sure. I'm pretty sure. That's my answer. Stick to it.
You're right. Yeah, two people that you use, and three people that you can watch and. Yeah. So, and that's like. that's why I picked you, because- Put it all outside, put it all back in.
honestly, what I'm hoping is if I saw all things stuff on Facebook, whatever's left, I guess, whatever's left, hoping that, so like I can do, when he gave this to me, I just, I'm all moved out, I have everything out of the house and this out, or do I use the? No. If I get one. I can just put whatever's left, but I want to sell it in case the girls don't want to take it. That's all it is. Oh, okay, okay. Post yard sale. So your answer is.